So we'll move on to our next speaker, who doesn't really need any introduction, partly because he's already introduced himself as a chairman. So I'll hand over to Antony. He's going to talk about understanding and reducing the impact of fragility fracture. Thanks.
We do have a perfect storm at the moment. We've heard today that we've got Welsh government, they've really nailed themselves to doing this. We've got commitment from the minister. We've got Chris Jones being very clear that it's unacceptable. It's legally unacceptable to be not doing this to patients. We've heard that it costs 3 times as much. If you want to write a business case, it's difficult. It costs 3 times as much not to have a fracture liaison service as it does to have one. We've got brilliant support offered by Craig on behalf of the ROS. They've got all of the numbers that you could possibly need. They've got all the templates. They've done this. They've written business cases in the past. They're there. You could just nick somebody else's. It's not different in another health board. It's going to be the same words, the same things you need to put together. There is support for doing that from the ROS. You've heard from Ali Doyle talking about the Academy network. That makes available networking support for people trying to do this who might feel isolated, particularly if you're working in an area where there just isn't any leadership for this and you're trying to take this on. And then the final thing that Peter talked about is the need that if you're going to try and do this, you need to be able to evaluate and prove that what you're doing is working. And proving that for fracture liaison services isn't as complicated as you think. You do not have to prove that you're reducing fracture numbers. That's a really difficult piece of research to do. What we know is that patients who've got a bisphosphonate in them don't break as often as people who haven't. Patients who are on osteoporosis treatment don't break as much if they fall as people who aren't. So you need to just be delivering people who are on treatment. And we have a national clinical audit, the Fracture Liaison database, that provides you with the feedback. And Linda showed us exactly that sort of feedback, that graph that she showed of the impact of turning up to work and transforming things in her hospital. She didn't have to do any work for that graph to appear in an authoritative output from the College of Physicians. She had an enormous amount of work to get the data in to do that, but she didn't have to create the demonstration of her effectiveness. The National Hip Fracture Database, which is the one that I've been most involved with, is using hip fracture as a way of challenging the NHS, looking at what happens to somebody who's old, breaks a hip, how they managed as they bounce through the complex systems within a hospital. It's not just about broken bones. It's not about the metalwork. I don't care about the metalwork at all. And the patient doesn't know what it is. It doesn't matter. It's about the person and their experience of passing through the modern NHS, which is often really very poor and a real struggle for them. And one aspect of that is osteoporosis management. And we've got data for all of the hospitals to look at numbers of hip fractures in different areas, what's happening to those patients and the quality of care being offered. Take an ideal hospital to choose for an example in a situation like this. So this is Usman's service in Neville Hall before Neville Hall was taken over in the greater concern of a wider Gwent model. But we've got key performance indicators which measure the quality of the service that's being provided there. Those figures give you a really clear idea of what happens to that patient and what her experience is when she comes into a hospital with hip fracture. That data is all freely available. You can look it up on your phone now for my hospital, for your hospital. It's all immediately available, and the data that pours into it is live and very accessible. Even if you're on the best of treatment, there's still a risk. So in this study, we've taken data from people who presented 4 years ago with a hip fracture, who went into the care of a fracture liaison service. They had all the bells and whistles of support. They had the best possible, best available UK treatment, and still 1 in 20 of them broke their hip. So even with the best of treatment, we can't eradicate risk of hip fracture, but many of us are working in hospitals where that process isn't tried at all, and large numbers, more patients will be back with a new hip fracture. And I'm sure you all have met people in with their second fracture, their third fracture, their fourth fracture, who you know the name of the patient when they turn up. It's a dreadful thing, and it's our fault. It's not their fault. It's our fault that these people are coming back to us. So we need to challenge that.